Okay, everyone, we'll go ahead and get started. My name is Brittany Allison. I'm a current PGY1 resident here at Advent Health Orlando. This presentation is part of the regularly scheduled series from the University of Florida College of Pharmacy. And these are the regularly scheduled series objectives. Neither me or my advisor have anything to disclose. In order to receive continuing education credit for this presentation, you will have to fill out the evaluation that will be sent out via email after the presentation is completed. Today, I will be discussing atrial fibrillation in critically ill patients. The objectives for this presentation include understanding the pathophysiology of AFib in critically ill patients, being able to recognize who is at risk for AFib, to compare various treatment strategies, and to evaluate the role of anticoagulation in this patient population. Atrial fibrillation, also referred to as AFib, is one of the most common arrhythmias seen in clinical practice. It is a type of supraventricular tachycardia that is defined by abnormal and unorganized rapid atrial electrical activity that leads to ineffective atrial contractions that are often out of sync with the ventricles of the heart. This can be seen on an ECG as irregular R to R intervals and absences of distinct repeating P waves. To the right of the screen, you can see that atrial fibrillation, what it may look like on an ECG in a patient compared to a patient that is in normal sinus rhythm. The pathophysiology of AFib involves alterations of the heart leading to this arrhythmogenic atria. These alterations can be structural or electrical in nature. In the general population, advanced age and chronic disease states such as congestive heart failure, diabetes, and chronic kidney disease can increase the risk for reactive oxygen species and inflammation, leading to atrial fibrosis and atrial scarring. These things lead to structural remodeling of the atria. Electrical remodeling can occur from persistent tachycardia can cause increases in intercellular calcium levels. Other alterations such as ionized calcium or ionized sodium concentration changes can lead to alterations in the signaling conduction. Both electrical and structural remodeling contribute to this formation of this arrhythmogenic atria. Risk factors for AFib include several of the points that we mentioned on the previous screen in the pathophysiology, such as age and cardiac and non-cardiac comorbidities, but it also includes modifiable risk factors such as smoking, alcohol consumption, and physical inactivity. Post-cardiac and non-cardiac surgery patients are also at risk, and our hospitalized patients with acute illness are at an increased risk for AFib, regardless of the presence of these other chronic risk factors that we have talked about today. So in today's presentation, we will focus specifically on critically ill patients that are admitted into our intensive care units. In order to understand why our critically ill patients are at risk for AFib, we can look at the pathophysiology in acute illness. In critically ill patients, structural and electrical remodeling occur more rapidly. Things like surgery and bacterial infections can lead to systemic inflammation that directly damages the atrial myocytes. Bacteria can also directly cause atrial fibrosis when it comes in contact with the myocardium. Volume overload can lead to atrial stretch and contribute to the structural remodeling as well. Tachycardia and bacterial toxins may alter ion channel expressions that leads to atrial remodeling in these patients, or electrical remodeling, excuse me. Once this atrial remodeling has occurred, it makes the atria susceptible to the development of AFib in the presence of certain triggers. These triggers of AFib can include vasopressors, sepsis, ventilator dysynchrony, and other causes of adrenergic stimulation. When we look at the incidence of AFib in our hospitalized patients, there is a significant incidence in our patients who have recent cardiac and non-cardiac surgeries. In today's presentation, we will focus specifically on our medically ill patient population, which have an incidence rate between 6 and 26%. So we know that there is a high risk for atrial fibrillation in our critically ill patients, but why do we care? What are the implications of this AFib in this setting? Short-term implications can include a fourfold increase in the risk for hospital embolic stroke, an overall increase in ICU length of stay by about 3.5 days, and a 7% increase in the risk of hospital mortality. These implications, however, are not limited to the acute setting, and we also see long-term implications, including a reoccurrence rate of around 50% in these patients within the first year after hospital discharge. After hospital discharge, these patients are also at an increased risk for hospitalizations due to heart failure and ischemic stroke. In order to look more into these long-term implications, I wanted to first look at a study that evaluated these patients and the long-term effects. So this was a study that looked at a sample of Medicare patients who survived hospitalization with sepsis. Septic patients accounted for a large portion of medically ill patients, and a lot of the published data in the critically ill is in the septic population. So this study grouped patients based on the presence or absence of AFib and compared patients who did not have AFib, patients who had prior AFib, to patients with new onset AFib. It included over 100,000 patients, with all patients being at least 67 years old, with the average age being around 80. Patients were identified as having a diagnosis of sepsis and AFib based on ICD-9 codes. Of these Medicare patients hospitalized with sepsis, approximately 7% experienced new onset AFib during their hospitalization, and this aligns with that 6 to 26% range that we've seen in our medically critically ill patients. And what they found was a statistically significant increase in all-cause mortality in patients who had new onset AFib compared to patients that did not. Patients with new onset AFib had an increase of about 4% in mortality, and this was seen throughout the entire 5-year study period, with increased risk starting less than a year after hospital discharge. These patients were found to have a 22% increase in risk of ischemic stroke as well. While anticoagulation was not reported in the study, it is important to note that approximately 99% of the patients had a CHA2DS2 score greater than or equal to 2. Almost 50% of the patients that did have an ischemic stroke did not have another diagnosis for AFib after their hospital discharge. Additionally, patients with new onset AFib during their hospitalization were at a 25% increased risk for hospitalizations due to heart failure when compared to patients who did not. From this study, we can conclude that patients with sepsis who develop new onset AFib have worse long-term outcomes compared to patients who do not. This brings me to my first assessment question. Which of the following statements is true? A, only patients with chronic risk factors are at risk for atrial fibrillation when critically ill. B, critically ill medical patients are at a higher risk for developing AFib compared to post-cardiac surgery patients. C, critically ill patients with atrial fibrillation are at a higher risk of recurrence after illness resolution. D, the presence of AFib does not affect hospital mortality. And you should be able to join the poll and answer, and I'll give you a few minutes to answer the question. Okay, so it looks like the majority of people picked C, and that is the true statement here. Critically ill patients who develop AFib in the acute setting are at a higher risk for reoccurrence after illness resolution. And if you remember previously in the presentation, we discussed how about 50% of patients would have a reoccurrence within the first year after hospital discharge. A here is incorrect because critically ill patients are still at risk, whether or not they have chronic risk factors or not. B is untrue because cardiac surgery patients are at a higher risk than our medically ill population. And D is not true because patients with AFib are at this increased risk of hospital mortality. Now let's look at how we can treat patients who have atrial fibrillation. The 2020 ESC treatment guidelines offer us recommendations for short and long-term therapy in patients with AFib in the general population. These guidelines recommend cardioversion in our unstable patients and discuss various rate and rhythm control options, as well as give us recommendations for anticoagulation. However, these guidelines offer us very little information on how to treat patients with new onset AFib during a critical illness. Today, we'll discuss how we can treat this population with the limited data and guidance that is currently available. Let's first look at our initial approach to new onset atrial fibrillation treatment, with our first step being stabilization in these patients. A lot of our critically ill patients will be unstable at presentation, and patients in our intensive care unit often have a multitude of reasons for this instability. First, it's important to determine if the instability is due to the new onset atrial fibrillation or if it's due to some other cause, which can be determined by a clinical assessment. If the instability is thought to be due to the abnormal rhythm itself, electrical cardioversion would be our first-line therapy in those patients. Once we have our patients stabilized, correction of potential underlying causes of the new onset AFib should be attempted. So let's think back to our potential causes of atrial remodeling and those triggers that we discussed at the beginning of the presentation to help us better understand the underlying cause, what it might be in these patients. First, ensuring that electrolyte abnormalities have been corrected and checking electrolytes such as potassium and magnesium regularly to ensure they're staying within range. Optimization of volume status to avoid fluid overload, which may lead to atrial stretch, and avoiding volume depletion that may lead to increase in vasopressor requirements. Treating our other disease states such as myocardial ischemia and bacterial infections. And lastly, if possible, discontinuing causative agents. In cases of beta agonists, this discontinuation might not be possible, but it may be beneficial to use agents that have less beta activity. So for example, if we have a patient who's on epinephrine drip, looking into if we can switch them to a norepinephrine drip. If AFib does persist after we've addressed these correctable underlying causes, we can consider treatment with pharmacological therapy. There are two major approaches to the treatment of AFib, including rate and rhythm control. Each strategy has advantages and disadvantages that are routinely debated. Rate control can help us avoid tachycardia-induced cardiomyopathy and help us improve ventricular filling by allowing more time in diastole. But these medications can have vasodilatory and negative inotropic effects that may limit their use in our critically ill patients. Rhythm control can decrease symptoms that are related to the abnormal rhythm, but these medications are often associated with toxicity. Additionally, rhythm control has limited effectiveness in our critically ill patients, and in some cases, rate control may be our only achievable goal. Unfortunately, there are limited randomized controlled trials that compare the two strategies in our critically ill patients, but to better understand the current literature that we do have available, I wanted to first look at the data we have in the general population. This was a meta-analysis conducted looking at 5 randomized controlled trials comparing rate versus rhythm control in these studies, and their rate versus rhythm control and their effect on all-cause mortality. Patients included had persistent or recurrent AFib, and the most common rate controlling agents used were beta blockers, calcium channel blockers, and digoxin. The most commonly rhythm control agents used were amiodarone, sotalol, and propafenone. These randomized control trials had a wide variety of follow-up to assess this mortality, ranging from 1 to 5 years. They also had varying heart rate targets in the rate control groups and a wide range of success in their rhythm control groups, ranging from 38% to 73% in success rate. All-cause mortality did occur in 13% of patients in the rate control group and 14.6% of patients in the rhythm control group. This difference, however, was not found to be statistically significant. While none of the individual studies found a statistically significant difference, if we look at the forest plot, we can see that the smaller studies had a less reliable, wider confidence interval, while the largest study, the AFFIRM trial, tended to have trended towards rate control, providing more mortality benefit. This meta-analysis gives us a quick overview of the data comparing the two strategies in the general population, but how can we translate this to our critically ill patients? That brings me to our next study that compares hospital mortality based on the treatment strategy, specifically in our critically ill population. This was a single-center retrospective study that included patients admitted to the medical ICU that had sepsis or septic shock. It's also important to note that this study excluded patients who had recent surgery or had a history of pre-existing AFib. 503 patients were included in the study. 263 did not experience AFib, while 240 did have new onset AFib, and that was defined as an absence of P waves and irregular ventricular activity lasting more than 30 seconds, as seen on a 12-lead ECG. Of the patients that had new onset AFib, 75 were noted to have persistent or recurrent AFib after 7 days of onset, while the other 165 had restoration to normal sinus rhythm within that 7 days. The choice of treatment strategy was left up to the treating providers, but there was no significant difference in pharmacological therapy between groups. Patients who developed new onset AFib were significantly older and had more cardiovascular risk factors compared to the group who did not develop AFib. And patients that had the sustained and recurrent AFib required more vasopressor support and trended towards higher severity of illness when looking at Apache 2 and SOFA scores between groups. The primary endpoint of the study, hospital mortality, was increased in patients who developed new onset AFib compared to those who did not. Those that had sustained or recurrent AFib had a 35% increase in mortality compared to those who had AFib and converted to normal sinus rhythm. These differences in mortality were each found to be statistically significant. Patients that had new onset AFib also had a longer ICU stay of 17 days compared to 11 days. Due to the differences in baseline characteristics, the author did decide to do a multivariant logistical regressional analysis to determine if these differences in mortality was due to the rhythm itself or some other factor. The analysis accounted for age, left ventricular ejection fraction, cardiovascular disease, SOFA scores, hepatic or renal dysfunction, and vasopressor use. This multivariant analysis revealed failure to restore sinus rhythm was an independent risk factor for hospital mortality. The study did find this independent association between mortality and a failure to restore to sinus rhythm. There is still concern for potential biases and differences between groups that might not have been accounted for. However, the study does show us potential benefit in restoring normal sinus rhythm and brings light to the possibility that rhythm control may be a good option for these patients. So now that we have looked at some data comparing rate versus rhythm control, let's look at each individual strategy. We can start with rate control. Our most commonly used agents for rate control include beta blockers, non-dihydroxyurea calcium channel blockers, amiodarone, and digoxin. These classes each affect the AV nodal conduction, resulting in a decrease in heart rate. There are various considerations for each agent that may help us determine what is the best agent for our patients. You can look at the available literature to determine which agents might be best for our critically ill population. Diltiazem, a non-dihydroxyurea calcium channel blocker, is one of our most commonly used agents in our critically ill patients. So I'll start out by comparing a study that looks at diltiazem compared to amiodarone. This was a prospective randomized controlled trial that included critically ill patients with recent onset atrial tachyarrhythmias. These tachyarrhythmias were defined as a heart rate greater than 120 beats per minute for 30 minutes, but their criteria for what they considered to be recent onset was not defined in this study. A total of 60 patients were included and randomized to either a diltiazem bolus followed by a continuous infusion, a amiodarone bolus alone, or an amiodarone bolus followed by continuous infusion. The primary endpoint of the study was a reduction in heart rate by greater than 30% within 4 hours of the medication administration. The widely accepted rate control goal for patients with AFib is less than 110 beats per minute, with the average heart rate in the patients in this study being around 140. The primary outcome of a 30% reduction would be targeting around 100 beats per minute, and that would be in line with our goal of less than 110. It's also important to note here that the bolus dose of amiodarone and the drip rate of diltiazem were slightly higher than we would typically see in practice. The primary endpoint of a greater than 30% reduction was not statistically significant between the three groups. However, there were more patients that had a heart rate greater than 120 beats per minute in the group who received the amio bolus alone. Amiodarone and diltiazem had similar effectiveness for rate control when amiodarone was given as a bolus followed by continuous infusion. There was more discontinuation due to hypotension in the diltiazem group. So to summarize the study, diltiazem, while an effective agent, Its use is limited by hypotension. So let's move on to compare the effectiveness of some of our other rate controlling agents. This was a retrospective multi-center cohort study that included patients admitted to the intensive care unit with a diagnosis of sepsis and atrial fibrillation with rapid ventricular response. The study used a heart rate of less than 110 beats per minute to define rate control. And patients were included if they were treated with IV AFib medication and had a rate that was greater than 110 at the time of medication initiation. A total of 666 patients were included, and half of those patients received amiodarone, while only around 10% initially received beta blockers. At baseline, patients who were treated with amiodarone had lower mean arterial pressures and higher severity of illness compared to the other treatment groups. Looking at the mean heart rate reduction, you can see that beta blockers had a significantly greater reduction in heart rate compared to all the other agents that were assessed. When we look at the graph to the right of the screen, looking at the results at 6 hours, they were very different, and beta blockers were only seen to be superior to digoxin at that time point and had similar rate reduction compared to calcium channel blockers and amiodarone. When considering the safety of these agents, patients who received amiodarone had an increase in hospital mortality and an increase in vasopressor support, although the exact pressor requirements of these patients was not defined. This could be a reflection of the differences in baseline characteristics between our groups. Beta blockers did not lead to an increase in hypotension or vasopressor requirements, meaning that they may have very little negative impact for our unstable critically ill patients. Overall, beta blockers resulted in a greater heart rate reduction compared to the other agents at the first hour, and were found to be similar after 6 hours. While the study did find this benefit with beta blockers, only 10% of the patients initially received beta blockers that were included in this study. So that brings me to my next study that compared outcomes, specifically mortality, based on what rate control agent was used. But this study included a larger population with a larger proportion of patients receiving beta blockers. This was a retrospective cohort study that used billing data from 20% of U.S. hospitals, and they included patients using ICD-9 codes to determine the patients that had a diagnosis of sepsis and AFib. All patients with a diagnosis of AFib were included, whether it was new onset or pre-existing. Over 39,000 patients were included in the study, with about 28% of patients receiving beta blockers. As you can see, each of our commonly used agents had a pretty good representation in this study. While admission to the intensive care unit was not a requirement of this study, about 59% of patients were admitted to the ICU. Based on a preliminary analysis, they decided to compare each of these agents to beta blockers specifically. First, we can look at their comparison between beta blockers and calcium channel blockers. When we look at the forest plot, you can see that there was a reduction in mortality when looking at all patients and when looking specifically at patients who were on vasopressors. But this mortality benefit was not seen when looking specifically at patients that had new onset atrial fibrillation. When comparing beta blockers to amiodarone, all patient groups had a significant mortality benefit with beta blockers when compared to amiodarone. While it is important to note that patients that received amiodarone were more likely to be admitted to the intensive care unit compared to the other groups, and that may have played a role in these results. Mortality benefit with beta blockers was seen in all patient populations when comparing it to digoxin as well, although selection bias may have played a role here. This study did have several limitations, such as ICD-9 codes used to dictate diagnosis, and it was a retrospective design, so it could have led to some selection bias. While almost 60% of the patients were critically ill, it was not a requirement of the study, and patients that had pre-existing AFib were also included. However, we can use these subgroup analyses looking at patients that have new onset AFib and those who are requiring vasopressors help us draw conclusions about our medically ill population. Beta blockers appeared to have mortality benefit in this patient population compared to all the other studied agents. Beta blockers were shown to have benefit specifically in patients that were requiring vasopressor therapy. These results may reflect the theoretical benefit that beta blockers have in sepsis, such as enhanced microvascular integrity, anti-inflammatory properties, and a decrease in beta adrenergic stimulation. When we compare our rate control agents, beta blockers have been shown to be the most effective rate controlling agent in our critically ill patients. They have been shown to have mortality benefit and maintain this benefit in patients who are requiring vasopressors. Calcium channel blockers showed similar rate controlling effectiveness while having less benefit in that patient population who requires vasopressors. Calcium channel blockers should also be used with caution in patients who have hypotension. Amiodarone has been shown to have similar effectiveness, while in the retrospective studies, amiodarone trended towards having worse outcomes. But it's important to note that treatment was left up to providers, and patient-specific factors such as hemodynamics may have influenced their decision to use amiodarone. Unfortunately, these unknown factors may have affected our current retrospective literature that we have available. Digoxin was shown to be less effective for rate control compared to the other agents, and this may be due to an increase in sympathetic drive that is seen in our critically ill patients. So this brings me to my next assessment question: which agent would be the best option for critically ill patient that has atrial fibrillation with rapid ventricular response, who is hypotensive and requiring vasopressors? So it looks like we kind of have mixed answers here. So it's kind of a tricky question because the answer is E, either beta blockers or amiodarone. We should consider avoiding diltiazem in patients who are hypotensive when there's other options that can be used. Beta blockers and amiodarone have been shown to be effective in the presence of hypotension and vasopressor use. While we do have that added mortality benefit that's been shown with beta blockers in that patient population, so that may have been why the majority of you picked B. While digoxin has not been shown to be effective in this patient population, so that would be incorrect. So now that we have discussed our various treatment options for rate control, that can lead us to our second treatment strategy, which is rhythm control. Rhythm control is a treatment strategy that targets the restoration of normal sinus rhythm. And there are two methods that we can use to attempt conversion in these patients: electrical cardioversion or pharmacological cardioversion. Starting out with electrical cardioversion, when we look at patients who are hemodynamically unstable and the instability is thought to be due to the abnormal rhythm, electrical cardioversion should be attempted. While this method does have limited effectiveness in our critically ill population, and successful conversions are often short-lived, with about 23% of patients maintaining normal sinus rhythm 24 hours after conversion. To better understand this effectiveness of electrical cardioversion and the effects it has on outcomes in this patient population, we can look at a subgroup analysis of a multi-center observational study, the After ICU study. This analysis looked at non-cardiac ICU patients with new onset atrial fibrillation in order to determine success rates of electrical cardioversion. Patients were included who received electrical cardioversion within 7 days of atrial fibrillation onset. The study included 65 patients, and of those patients, only 40% had a restoration of sinus rhythm after the first shock. Successful shock was defined as a restoration of sinus rhythm for at least 30 seconds. And on the diagram to the left of the screen, you can see that the success rates actually decreased within each subsequent shock. Other factors that were assessed included pre-treatment with antiarrhythmic medications and the amount of joules that were used, and neither one were shown to affect success rates. Finally, we noted a high rate of reoccurrence, with 69% of patients that had successful cardioversion experienced a reoccurrence within 24 hours. This study demonstrated that there are low rates of success in this patient population and high rates of reoccurrence. So in our patients that we do have successful cardioversion, is that restoration of sinus rhythm improving their hemodynamics when we look at our critically ill patients? This was a study that evaluated the effects of successful cardioversion on vasopressor requirements. This was a single center retrospective study that included patients admitted to the cardiosurgical intensive care unit who were hemodynamically unstable, had new onset atrial fibrillation, and underwent a cardioversion that was successful. Hemodynamic instability in these patients was defined as a norepinephrine requirement of at least 0.1 micrograms per kilogram per minute, or the need for positive inotropic agents. New onset AFib was defined as AFib with an onset of less than 7 days, and a successful cardioversion was defined as an achievement of sinus rhythm for at least 30 seconds. The primary outcome in this study was a change in norepinephrine or inotropic requirements 6 hours after successful cardioversion. As you can see on the figure to the right of the screen, there was a significant increase in vasopressor requirements immediately following cardioversion. This may have been due to sedative agents that were used for the procedure or atrial stunning that occurred after the cardioversion. Compared to baseline, norepinephrine requirements did decrease at the 6-hour mark by about 0.02 micrograms per kilogram per minute, but this difference was not statistically significant, nor was it clinically significant. Overall, successful cardioversion did not improve hemodynamics in most critically ill patients, and this may be because the instability in these patients is not due to the atrial fibrillation, but due to some other cause. Now that we have looked at the utility of electrical cardioversion, we can look at our treatment options for pharmacological cardioversion. Pharmacological cardioversion can be attempted with a wide variety of antiarrhythmic medications, but today we will talk about a few of those medications that have been looked at in our critically ill patients that include amiodarone, magnesium, procainamide, and albuterol. Amiodarone is one of the most used agents for this patient population because of its relative hemodynamic neutrality and its effectiveness for not only rate control, but also rhythm control. This study was a prospective randomized controlled trial comparing amiodarone to procainamide in patients admitted to the intensive care unit with atrial tachyarrhythmias. These arrhythmias included a flutter, AFib with a heart rate of greater than 110 beats per minute, and supraventricular tachycardia with a heart rate greater than 140. Before inclusion, patients must have failed response to correction of underlying causes such as potassium, magnesium, hypoxia, and or acidosis. And patients were excluded if they had a systolic blood pressure less than 80, or they had recent cardiac surgery or chronic atrial fibrillation. 24 patients were included, 14 patients received procainamide, and 10 patients received amiodarone. Each regimen consisted of a bolus dose followed by continuous infusion. Each group had similar baseline characteristics with a mean heart rate of around 160 beats per minute in both groups. Procainamide and amiodarone appeared to be equally effective for the treatment of atrial tachyarrhythmias in this critically ill patient, and there was not a difference in conversion to sinus rhythm, and neither medication had a significant effect on systolic blood pressure. Patients who did not convert to sinus rhythm were evaluated for a decrease in heart rate by greater than 20 beats per minute, and it was found that procainamide and amiodarone had similar heart rate lowering effects as well. While procainamide has been shown to be equally effective as amiodarone, its use is limited in this population due to its contraindications in patients with structural heart disease and heart failure. In addition to amiodarone, magnesium sulfate has also been used regularly as an antiarrhythmic for our critically ill patients. The next study I wanted to discuss is a prospective randomized controlled trial comparing amiodarone to magnesium for the conversion of atrial tachyarrhythmias. This study included patients with sustained tachyarrhythmias with a heart rate of greater than or equal to 120 beats per minute. They excluded patients with systolic blood pressure less than 80 or those who had significant kidney dysfunction. Underlying factors such as electrolyte abnormalities were corrected before randomization. A total of 42 patients were included in the study, half being medically ill patients and half being surgical patients. 8 patients were found to have chronic atrial fibrillation after randomization occurred, and those patients were excluded from the final analysis. The final evaluation included 18 patients in the magnesium group and 16 patients in the amiodarone group. 3 patients who were randomized to the magnesium group were transitioned to amiodarone due to uncontrolled ventricular rates, and those patients were excluded after that transition occurred. 2 patients in the amiodarone group did die, so only 14 patients were evaluated at the 24-hour mark. Of note, digoxin was used in the study in about 50% of patients, and epinephrine was used in about 30% of patients, which may have affected our conversion rate. 77% of patients who received magnesium converted to normal sinus rhythm, while only around 43% of patients who received amiodarone had the same conversion. Magnesium's conversion rate was better than amiodarone, and it may be a reasonable option for rhythm control in our critically ill patients. So what other agents have been looked at in this patient population? Albuterol is a rarely used drug, but has been looked at for its use in critically ill patients. This study was an open-label, non-randomized, prospective trial conducted at a single center to assess the use of albuterol for atrial fibrillation in the ICU. Patients included in the study were admitted to the intensive care unit, had a new onset atrial fibrillation that was sustained for greater than 10 minutes, and had a heart rate of greater than 100 beats per minute. Patients were excluded if they weighed less than 60 kilograms, had a QTc of greater than 440, had a recent acute coronary syndrome, or had a history of ventricular tachycardia. 37 patients were included, 17 were medically ill, and 20 were cardiac surgery patients. It's important to note the medically ill patients did have a higher severity of illness when looking at SAPS-2 scores and had a higher baseline heart rate compared to the surgery patients. Patients that were included received 1 milligram of albuterol infused over 10 minutes, followed by a repeat dose after 10 minutes if needed. Successful cardioversion was defined as the termination of AFib or a flutter within 60 minutes of the first infusion. Conversion to sinus rhythm was successful in 56.8% of patients. Of the 4 patients that had a flutter, all of those patients had successful conversion to sinus rhythm. The overall success rate was higher in medically ill patients when compared to surgically ill patients, with a conversion rate of over 80% in our medically ill population. Premature ventricular complexes occurred in 32.4% of patients, and serious ventricular arrhythmias that required discontinuation of therapy occurred in 8.1% of patients. Of the 3 patients that experienced this serious ventricular arrhythmia, 2 patients had an ejection fraction that were less than 20. This may have contributed to the risk of the arrhythmias in those patients. While albuterol has one of the highest conversion rates of the agents we've talked about today, its serious adverse effects do limit its use. To summarize our options for rhythm control, the first step is to determine if the hemodynamic instability is due to the AFib, and if it is, electrical cardioversion would be our first line. While, as we discussed, that this strategy does have decreased effectiveness in our critically ill patients and has a high rate of reoccurrence. Magnesium, amiodarone, procainamide, and albuterol have all been studied in our critically ill patients and shown to be effective in converting patients to sinus rhythm. Magnesium has been shown to be more effective than amiodarone and associated with fewer medication toxicities. Amiodarone and procainamide have been shown to have similar effectiveness, although procainamide's contraindications do limit its use. Albuterol has impressive conversion rates of over 80% in our medically ill patients, but it should be used with caution, especially in patients who have a decreased left ventricular ejection fraction at baseline. So how do we decide on which strategy to use in our patients, rate or rhythm control? Each strategy has similar outcomes in the general population, but there's limited data in our critically ill. Rate controlling agents have less potential for adverse effects, and agents such as beta blockers have been shown to have mortality benefit in our patients with septic shock. However, patients who convert to sinus rhythm have been shown to have better outcomes compared to those who do not. And patients who are reliant on atrial contraction and have a cardiac output that's highly dependent on preload, those patients may not tolerate the abnormal rhythm regardless of rate control. Because of this, patients with decompensated heart failure or severe aortic stenosis may benefit more from rhythm control. Although it's important to remember that rhythm control agents do not have a 100% success rate, and in some cases, rate control might be the only achievable goal in these patients. So earlier in this presentation, we discussed the increased risk of mortality and ischemic stroke that these patients have who develop new onset AFib in the acute setting. We have discussed the possible treatment options for AFib, but how are we going to address this increased risk of stroke in these patients? Whether or not to use anticoagulation in these patients is a frequently asked question in our intensive care units. The 2020 ESC guidelines recommend anticoagulation in patients with AFib who are at risk for stroke as determined by the CHADS-2 VAS score. The evidence directing these guidelines was taken from the general population, and the CHADS-2 VAS score validation studies did not include critically ill patients. I want to review the data that is available for the use of anticoagulation in our critically ill patients. So this was a retrospective study that assessed outcomes associated with anticoagulation in patients with sepsis. They included patients that had a diagnosis of sepsis and atrial fibrillation as determined by ICD-9 codes, and they excluded patients who received oral anticoagulation and those who had another indication for anticoagulation other than AFib. Patients were not required to be admitted to the intensive care unit, and those that had pre-existing AFib were included. The study assessed over 38,000 patients, with around 35% of those patients receiving anticoagulation, which was defined as IV or sub-Q anticoagulation at doses greater than prophylactic doses. A propensity score match was completed to adjust for various factors such as age, history of heart failure, admission to the intensive care unit, and CHADS-2 VAS scores. This analysis included 27,000 patients and assessed for an occurrence rate of in-hospital ischemic stroke and clinically significant bleeding, which was defined as bleeding that required a blood transfusion. They found there was no difference in ischemic stroke during hospitalization between patients who received anticoagulation and those who did not. There was, however, an increase in clinically significant bleeding in the patients who received anticoagulation. When assessing patients that had new onset AFib, they found that those patients were at an increased risk of ischemic stroke compared to patients with pre-existing AFib. They also assessed the use of the CHADS-2 VAS score in patients with sepsis, and it was determined to be a poor predictor of ischemic stroke with a C statistic of 0.52. So critically ill patients with new onset AFib are at a 22% increased risk for ischemic stroke. Benefits of anticoagulation have been shown in the outpatient setting, but those benefits have not been replicated in the critically ill population. Anticoagulation was actually shown to be harmful in this setting. Patients should be assessed for the need for anticoagulation once the acute illness has resolved. Patients with new onset AFib should be assessed for risk factors and need for anticoagulation at the time of hospital discharge and should be instructed to follow up outpatient to reassess for AFib reoccurrence and the need for anticoagulation on a regular basis. This brings me to my next assessment question. Which of the following statements is not true about anticoagulation in our critically ill patients? A, patients with new onset AFib are at an increased risk for thromboembolic events after hospital discharge. B, anticoagulation in critically ill patients increases the risk of clinically significant bleeding. C, anticoagulation has been shown to significantly decrease the risk of thromboembolic events in critically ill patients with new onset AFib. D, patients with a reoccurrence of AFib after hospital discharge should be evaluated for thromboembolic risk and to determine the need for anticoagulation. So it looks like the majority of people got this right. C is not true because anticoagulation has not been shown to decrease the risk of thromboembolic events in our critically ill patients. So in conclusion, it's not clear which treatment strategy is superior in our critically ill patients, but if we're opting for a rate control strategy, beta blockers have been shown to have mortality benefit in patients who have septic shock. For rhythm control, there are several options, with amiodarone and magnesium being our most well tolerated. Anticoagulation, however, has not been shown to be beneficial in this acute setting. Further studies are needed to determine some answers to our unanswered questions, such as whether or not rate versus rhythm control is superior, what is the optimal timing for initiation of anticoagulation in these patients, and what would be the best time frame and strategy to follow up for these patients and screen them for a reoccurrence of after the resolution of their new onset AFib during critical illness. While we do not have a clear one-size-fits-all treatment strategy for these patients, I hope this presentation makes you feel more confident about the current literature that is available and helps you aid your decision-making in the ICU. And that is everything I had. I will open the floor up to any questions. Yes, Jason.
So, is there any data to support
So Jason's question was if there's any data to support one beta blocker over another, and if so, like which one would I pick and why? I actually did not see any data when I was looking. It was usually beta blockers were grouped as as like one treatment group, but I can look into that and see if I can dig up anything else and get back to you on that one. Yeah.
For the study that we reported about patients who are on beta blockers and showing mortality benefits in non-clusters, those studies report any like mean or median dose of beta suppressor that's taken into consideration.
So that was actually, so Joanna asked if the studies that showed this benefit of beta blockers in patients who required vasopressors gave an exact like dose or mean dose of vasopressors in patients who required. This is actually a question I had as well, and I kind of dug into it, and they did not. It was really just if they were on it, which is unfortunate because when we're trying to look at our patients and apply this data to our patients, it would be nice to know, but they did not tell us the exact dose. Yes. I think, so OT's question was the study that compared amiodarone to magnesium. Would you opt for the continuous infusion that they use in the study, or would you do a different strategy? So because there's such limited data with this in the critically ill patients, I would probably opt for a strategy that mirrors what they did in this study where they had effectiveness. But I can definitely look into and see if there's any other strategies that have been shown to be effective. If no one else has any other questions, thank you so much for coming. I will send out an email later today.